Thank you for the kind introduction. I'll talk about my choice, the CoreValve for this case. As you all know, in Korea, two kinds of valves are available for TAVI procedure. One is Sapien XT valve, and on the other side, CoreValve. And these valves have different materials and different design, and also they have different mechanism of deployment. So Sapien valve is a balloon expandable stent basically, and CoreValve is a nitinol stent, and which is deployed by self-expansion. And Sapien valve is deployed quickly by balloon inflation, and CoreValve can be released more controlled, and it is partly repositionable and also retrievable. And both systems cover the similar range of annulus diameters. And these are the delivery systems of Sapien valve and CoreValve. In Korea, currently NovaFlex Plus is used. And basically the required minimal vessel diameter for these two systems are 6 millimeter. So two valve systems, delivery systems, they have a similar requirement for the vessel diameter. So I'd like to show the checklist for TAVI procedure. We can look at the indication, and also we measure annulus size using different kinds of imaging modalities. And also we will look at closely look at the aortic valve morphology, especially calcification pattern and amount, and also valve type, whether it is bicuspid or tricuspid valve. Also, we will look at the leaflet characteristics, such as whether it has long leaflet and bulky leaflets. And also aortic root morphology is very important, whether it is narrow or horizontally located. Also the distance of coronary ostia from leaflets are very important. And also if the aortic wall is calcified, then there is a higher risk of injury during the procedure. And also below the aortic valve, geometry is also important. If the patient has septal hypertrophy, especially LV out tract obstruction, then we have to be very careful, and sometimes it is severe, the hypertrophy is severe, then it is contraindicated for TAVI procedure. And also vascular access is an important focus. And when we focus on the aortic valve morphology, the calcium is an important factor for the TAVI procedure. So even distribution of calcium is ideal. And if there is uneven distribution of calcium, then there is an increased risk of paravalvular leakage. And also if there is bulky calcium, then the risk of calcific nodal displacement into the coronary ostia is increased. And especially when you have both, so bulky calcium and uneven distribution of calcium, then there is an increased risk of annulus rupture or root perforation. So if a patient has a heavily calcified aortic valve, so Sapien valve maybe has advantages in terms of better expansion and better opposition, and so that may result in less paravalvular leak, at least in early phase. But on the other hand, there is an increased risk of annular rupture during the procedure. And for the CoreValve, because of this self-expansion deployment mechanism, there is a less expansion and opposition in early phase, so it may result in more paravalvular leak in early phase. However, there is a lower risk of annular rupture during the procedure. And this patient does not have a bicuspid aortic valve, but in case of bicuspid aortic valve, there is an increased risk of uneven expansion and subsequent valve malfunction, and also risk of undersizing. There are different types of bicuspid aortic valve, and according to a paper, Sapien valve has better expansion at the level of annulus compared to CoreValve. However, in supravalvular level where the leaflets coapt, there is minimal deformation on the expansion for CoreValve. So basically, both systems work in bicuspid aortic valve. And also, as I told you already, the leaflet characteristics are important. Long leaflets may fold over the outflow aspect of the valve and impair prosthesis leaflet function. And also bulky leaflets, especially when the mass has size of more than 4 millimeter, that can obstruct coronary flow upon valve deployment. And the height of coronary ostia is very important. So because of the different design of these valve systems, the risk of coronary ostium occlusion by one of the aortic leaflets increases when the height of the coronary ostium decreases. So low coronary ostia, so below 14 millimeter, is associated with increased risk of coronary obstruction, especially for the Sapien valve. The minimum requirement for the distance is 10 to 11 millimeter. And because of the different design of the CoreValve, there is a waist in the middle of the device. There is a less risk of coronary occlusion during the procedure. So we had an interesting case of the coronary obstruction. This patient has the minimal disease coronary system. And the left main ostium has a distance of 11 millimeter. And in this case, actually, we plan to implant a Sapien valve, and our plan was approved by the company. And this was the image during the procedure. As you can see, there is a protrusion of the calcium mass of the leaflets into the left main during the balloon inflation. So as we find out this figure, so we decided to change to a CoreValve system instead of a Sapien valve, and we successfully implanted CoreValve. And this is the CT image after the TAVI procedure. This is before procedure, and this is after procedure. And this is calcified leaflet. And after the procedure, you can see this calcium mass now located just in front of the left main. So there is minimally, there is some obstruction of the left main after the procedure. So we decided to implant a stent, and now the left main was secured by implanting our stent. And there are also different mechanisms of coronary obstruction. This is a bulky leaflet which occludes left main, and also the device itself can occlude the left main ostium. So occlusion of coronary ostium occurs in about 1%, and the risk factors of the occlusions are low origin of coronary ostium, especially if the distance lower than 14 millimeter or 10 millimeter, and shallow sinus of valsalva, bulky native valve, eccentrically calcified aortic valve, and also the prosthesis design. And we have to talk about paravalvular leaks and the need for a permanent pacemaker. And as you all know, according to the Multicenter Registry, there is a slightly increased risk of paravalvular leak of moderate to severe in favor of in CoreValve. However, with time, the frequency of the moderate to severe aortic valve, aortic regurgitation decreases. This is the CoreValve US clinical trial data. So in the early phase, maybe the paravalvular leak is occurs more frequently with CoreValve, but with time, the percentage decreases. And also, there is an increased risk of complete AV dissociation with CoreValve. And this is CoreValve on the left side. On the right side, this is Sapien valve, and there is a higher risk of permanent pacemaker implantation in cases of CoreValves. This is explained by the design of the valves. So, however, there is no significant differences in terms of mortality across the registry and randomized trials. So the hard endpoint is similar between two different systems. So we have to focus on this patient. This patient is a 77-year-old female, and with severe aortic valve stenosis. Euroscore is not that high. However, this patient has this patient had a stroke, and there is also significant stenosis of MCA. So I think the indication is acceptable in this case. And this is the measurement done by doctors in the Sejong Hospital, and the perimeter is 83, so this is corresponding to 29 millimeter CoreValve. And this is the pattern of the calcification of the aortic valve, so they're evenly distributed and mostly located at the tip of the leaflets. and the length of the leaflets does not appear to be long. However, there is some mass of calcification, so I think there is also the distance of the right coronary ostium to the annulus is around 11 millimeters, so a little bit low the height of the right coronary ostium. On the left side, the left main ostium is a little bit far away from the annulus. However, actually the right coronary artery system is diminutive. So even though there is obstruction of the right coronary artery system, maybe the impact is not that high, but however, we have to avoid any kind of complication during the procedure. So, and also the vascular access from the femoral arteries is very good, so acceptable. I think we can perform this procedure by transfemoral approach. And this procedure will be done by Dr. Hyus Kim, and he has more experience with CoreValve than Sapien valve. And I think low volume centers should better focus on one valve system. And these are my summary. CoreValve and Sapien valve have different designs and mechanical characteristics. Both valves have advantages and disadvantages. And requirement of permanent pacemaker and only represent a paravalvular leak may be observed more frequently with CoreValve. However, both valve systems appear to have similar clinical outcomes in hard clinical endpoints. In this patient, the height of the right coronary ostium is relatively low, and the calcification of AV leaflets appears to be symmetric and localized at the leaflet tips. The operator has more experience with CoreValve, and my choice of valve is maybe I think both valve systems probably work well. However, I would recommend CoreValve because of relatively short distance of IC ostium to the annulus, and also the operator experience speaks for CoreValve. So my choice is CoreValve 29 millimeter by transfemoral approach. Thank you for your attention.